Hello, everyone. My name is Nancy Quinn, and I'm your moderator for today's presentations. Thank you for joining the Tourette Association of America and the International OCD Foundation for this two-part webinar. Part 1, Diagnosing TS and OCD, will be presented by Dr. John Piacentini. In Part 2, Behavioral Approaches for Treating TS and OCD, will be presented by Dr. Sabina Wilhelm. A brief 15-minute recess will occur between the presentations. Please remain logged in during the recess. Questions will be answered live at the end of each presentation. To ask a question, use the Your Question box located on the lower left-hand side of your screen. The presenters will answer as many questions as our scheduled time allows. Funding for this webinar is made possible in part by the Centers for Disease Control and Prevention. The views expressed in materials or publications and by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does a mention of trade names, commercial practices, or organizations imply endorsements by the U.S. government. Today's webinar will be archived and available for viewing free of charge in about 4 business days on the Tourette Association and the International OCD Foundation websites, where you'll find invaluable resources on TS and OCD. Finally, the last slide of each presentation contains a link to a brief evaluation. Please do take just a couple of minutes to let us know your thoughts and offer suggestions for future webinars. And now a very special welcome to our first presenter, Dr. Piacentini. Please begin.
Thank you, Nancy. It's really great to be able to do this, and I think it's the partnership of the Tourette Association of America and International OCD Foundation is a really great thing, and I think it these two wonderful organizations working together is going to hopefully really improve things for the families and sufferers of these disorders, and I'm excited to be part of this webinar. I just wanted to flash up my potential conflicts here. I have some research funding from both of these organizations over the years, as well as some other sources, and I do presentations and talks for these groups, as well as have some royalties from some books on these subjects as well. I'm not getting paid for this talk. Just to start very briefly with DSM-4 and DSM-5, there are a couple of changes for OCD and tic disorders in terms of diagnosis. The primary changes are the fact that the disorders have been moved to different sections of the DSM. So you may remember from DSM-4-TR, OCD was in the anxiety disorders section, and it has since been moved to a new section in DSM-5 called OCD and related disorders. And this OCD and related disorders contains a number of like-related disorders, such as trichotillomania and excoriation or skin-picking disorder, formerly in the impulse control disorders section. And for tic disorders, which were originally in the disorders first diagnosed in infancy, childhood, and adolescence, have now been moved to a new category called neurodevelopmental disorders, along with some related disorders, most specifically stereotypic movement disorders, which that's oftentimes a difficult differential diagnosis, so we're going to talk a little bit about how we're going to distinguish between tic and stereotypic movement disorders a little bit later in this presentation. So obsessive-compulsive disorder. And if you want to diagnose somebody with this obsessive-compulsive disorder, the first thing to do when I do talks, when I do live talks, is I flash up a crooked slide like this. And I look and see who's getting anxious because they don't like symmetry, and that's a good clue. Behavioral observation is critical in terms of diagnosing either of these disorders, especially with tics, which is obvious because you can look and see tics, when you're working with a family or a child or an adult, and oftentimes, even in the face of denial of symptoms, you can see some of these symptoms, which gives you some clues. Similarly with OCD, you're also going to be looking for reactions to different stimuli or questions, and behavioral assessments or probes, even in terms of mildly challenging your patients. Are they able to touch certain things or mess things up or arrange things asymmetrically? Symmetrically, even in the initial visit, can give you some clues in terms of how best to some ideas about the diagnosis. So we talked about the new OC and related disorders section in DSM-5. Here are the disorders that are included here: obsessive-compulsive disorder. There are a couple of changes, the primary changes, aside from some wording, cleaning up some wording, is there are now specifiers. So you would specify with levels of insight and delusional beliefs, and also you would specify whether or not the individual has lifetime comorbid tic disorder. Body dysmorphic disorder, trick, excoriation or skin picking, which is a new disorder, and hoarding are also in this section. So when we think about DSM-5 OCD, here are the criteria, and I'm not going to go through these in detail. I'm assuming they're familiar to most of you that are listening right now. But it really is the primary criteria are the presence of obsessions or compulsions, or both. And these obsessions are recurrent or persistent thought or urge or image that are experienced as intrusive or unwanted. Typically, the course may be early in the disorder. Their experience is intrusive or unwanted. Over time, the patient may grow to accept these and may not describe them in the same way anymore. In individuals with more fixed obsessions, in very severe OCD, it really can border almost delusional, and the person may not challenge these thoughts as unwanted on every instance. And the idea of obsessions would be that they would cause marked anxiety or distress, and this would lead to attempts to try to do something to make this thought go away, which is typically the compulsion.
Dr. Piacentini, this is Nancy. Sorry to interrupt you here, but the volume seems to be going up and down just a little bit. So if you could take that headset that we sent you and move the mouthpiece a little closer, perhaps that'll help with the volume.
Okay, how is this?
And just do a quick 1, 2, 3, please.
1, 2, 3.
I think it sounds fine. Thank you.
Okay, great. Sorry about that.
No problem. Thanks.
So compulsions are basically what the patient does to make the obsessions go away, and they can be behaviors or mental acts. And we think of compulsions in a couple of classes. One would be either something that is not realistically connected with the obsession. So, for example, a patient that is afraid of something bad happening to them, of, say, a family member dying or getting sick, and they may have to repeat things. They may have to do something 3 times in a row every time they do it, or they may need to spin around in circles or say certain words that are clearly not related to preventing that event in any logical fashion. The other common class of compulsions are behaviors that are clearly excessive but logically related, and the prototypic example of that would be excessive hand washing to address fears of contamination. In DSM-5, the obsessions and compulsions similar to DSM-4, the time-consuming, clinically significant distress, and impairment in important areas of functioning. The time-consuming criteria can be a little bit tricky, and a lot of people can get hung up on this because many OCD symptoms, especially mental intrusions, can be very brief. So a patient might have a thought or a worrisome thought or an unwanted thought flash into their head. It may last a second is all, and they may do something a very quick mental ritual, maybe saying a word to make that thought go away. And if you add all of this up, it may not total to an hour a day. There's somebody that may wash their hands for 15 or 20 minutes a day, but it can lead to impairment or distress in significant fashions. So we usually define time-consuming as either an hour a day or something that occurs frequently, ideally several times a day or a few times an hour or more in terms of making the diagnosis. And then as we noted, the specifiers would be good or fair insight, poor or absent insight, and then specify if tic related. Now, in terms of some of the facts and figures about OCD, it's a common disorder, about 1 to 3%. The prevalence is pretty similar across children, adolescents, and adults. What you do find with age is a difference in the gender ratio of the disorder. So pre-pubertal onset, when we look at children, we see higher rates of boys than girls. Post-pubertally and in adulthood, the ratio is about similar between males and females. Now, what's interesting about OCD is that really, I'm a child psychologist. I tend to think of OCD as a juvenile disorder. And the reason is that it's common, child onset is very common in adults. Even though the mean age of onset is a little under 20 years, A significant number of cases have an onset very young. About 25% of cases have an onset under 14 years of age, and a very significant proportion, much higher than that, have an onset while in adolescence still. We tend to see a bimodal distribution, so there's a prepubertal onset and then a young adult onset. We also can find exceptions to this. There's a postpartum OCD, which is somewhat common and occurs after pregnancy. OCD can also onset after other kinds of stressors. When we think of the juvenile onset, so when we think about young children with OCD, they have a higher proportion of males, as I mentioned earlier. You tend to see greater familiality, so other family members with OCD. Some of the genetic relationships that we find from the genetic studies tend to be stronger in these younger juvenile onset cases, and they're more likely to have comorbid tic disorders. Now, the onset can also be abrupt or can be gradual. It really depends. In the cases of gradual onset, in the cases of abrupt onset, and we've had parents that have come in and say, literally last week he started washing and it blew up, and we don't know where this came from. Oftentimes, almost always, if you dig deep enough, subclinical symptoms have been present for a longer period of time. They just haven't been recognized by those in the patient's life. And symptoms can wax and wane or be chronic and progressive. They get worse when the individual is sick or stressed or tired. And again, this isn't too different from many other disorders. The symptoms of OCD, the most common symptoms, have been tend to aggregate around 4 or 5 different factors depending on the study, but there's typically an aggression, harm factor, and that's often associated with checking compulsions, checking to make sure that nothing bad is going to happen, as an example. Contamination and obsessions and cleaning compulsions tend to go together, as do symmetry order obsessions and arranging compulsions. Hoarding oftentimes typically factors onto its own symptoms grouped together, and then sometimes you'll have a sexual or religious obsessions and mental compulsions factor as well. So these are symptoms that tend to hang together with each other. In terms of the course of the illness, there have been a couple of studies. One of the biggest has been a study by Macaulay and colleagues from the Maudsley OCD program in London, and they studied a number of kids over 9 years. These were peds OCD patients in their group, and they found 41% at a mean 9-year follow-up met criteria for full OCD. And this exactly matches another study by Evelyn Stewart with children that was done a little bit earlier that also found about 40% of their sample after a 1 to 15-year follow-up also met criteria for OCD. So in a large minority of cases, it can be a chronic disorder in terms of diagnosis. Other diagnoses, comorbidity was also quite common in the Stewart study as well. There was a pretty high rate of subclinical symptoms, so about 60% of the individuals in these studies had some OCD symptoms as well. And you can see in this study that 70% had another comorbid disorder. About half were receiving treatment, and most of them perceived a need for further treatment as well. And in this study, baseline tics predicted OCD remission, although that hasn't necessarily been the case in other studies. Most of these cases were treated. They came from a clinic sample, so we don't have as good of a sense of what the course is like in untreated or community samples. There was one study that made got a lot of attention when it came out a few years ago, a follow-up of adults with OCD at a 40-year follow-up. And this study found that 80% of these adults still had clinically significant symptoms, with the course being worse for those untreated as opposed to treated. So that's pretty significant in terms of this as a chronic disorder. And in our sense, most cases, you do see spontaneous remission in a minority of cases, but that's not so likely to happen in the absence of treatment. In terms of functional impairment, we find that OCD is associated with significant impairment, and at one point it was rated as one of the 10 most disabling medical conditions worldwide. I don't think it's still in the top 10, but it's very close to that. The other important thing to think about in terms of functioning is a study by Eric Hollander several years ago found a gap of 17 years between symptom onset and correct diagnosis, reflecting either shame, on the part of the patients or embarrassment about seeking help for their symptoms, or on the lack of education among healthcare providers in terms of recognizing the disorder. We'd like to think that gap has shrunk considerably now that OCD has become more familiar and more accepted as a disorder. But that can tell you, given the significant impact with the disorder and the long delays in receiving treatment, it can make it a significant problem. In terms of children, some research that we've done and others, most kids report at least one significant area of significant OCD-related dysfunction. And in our clinic sample, half of the kids that we see report significant OCD-related dysfunction across home and school and socially, so that their impairments are pervasive across all of the important domains of their functioning. Comorbidity is quite high in childhood OCD. This is some data from our program as well. In kids, other centers have reported even higher rates. But other anxiety disorders tend to be most common, with generalized anxiety disorder typically the most common among the anxiety disorders, ADHD, oppositional disorder, tic disorders, depression, and in our clinic, about 3/4 of kids come in with at least one comorbid disorder, and about a third come in with multiple comorbidities. Now, there's one cluster of comorbidity that you tend to see quite commonly. It's more common in children. It's more common in boys, and it's the triad of OCD, ADHD, and tics. And that can be difficult to treat because in terms of trying to do behavior therapy, the kids with ADHD oftentimes have a hard time paying attention and attending to their symptoms to be able to do the exposure. In terms of pharmacology, psychopharmacology, oftentimes the medications for one of these disorders can exacerbate the symptoms of the other. So these kids are a little bit more complicated to treat, and that's something to look out for. Whenever you see a child with any one of these three disorders, it's critically important to assess for the other two. OCPD symptoms in childhood, you see kids coming in with OCPD symptoms, and in these kids, the presence of these symptoms in children is going to predict an earlier OCD onset if these kids come in with subclinical OCD in a more severe and chronic course. And that's not too surprising, given that OCPD can be a bit more difficult to treat than straight OCD. Comorbidity and adult OCD, one thing that strikes you from the difference between these two slides is the fact that the comorbidity rates are higher. So there's a higher rate of other anxiety disorders. Major mood disorders are nearly ubiquitous in the samples, with up to 40% of patients, adult patients with OCD, experiencing major depression. OCPD in about 1/4 to 1/3, and tic disorders in up to 30%. You also find higher rates of OCD in other disorders. For example, 12% of schizophrenics are diagnosed with OCD, according to some research. And the prevalence, the other thing to take from this is that the prevalence of comorbid mood disorders tends to increase dramatically over age. So relatively less common in children, reasonably common in adults, and again, quite common, reasonably common in adolescents, and again, quite common in adults. Across the lifespan, OCD tends to follow other anxiety disorders, so it's most common to see a non-OCD anxiety disorder present first, with OCD onset maybe being a little bit later in age, and the mood disorders almost always follow, suggesting that they may be a secondary phenomenon to the OCD symptoms and reflect the burden of living with this disorder. Tic-related OCD is also pretty common, as we noted, and there have been a couple studies suggesting that OCD looks different when it's comorbid with tics than when it's not. And this is a study showing that individuals with OCD plus tics, and this was a study done with children and adolescents, are more likely to be male, to have an earlier age of onset, which we had noted before, and the type of symptoms that they have also tends to be a little bit different. So tic-related OCD, there tend to be more symmetry, ordering, and less contamination and harm avoidance. So it really is more kind of a just right OCD as opposed to a harm avoidance OCD. And this has led Charlie Mansueto and colleagues to describe Tourettic OCD. And it basically just recapitulates the information on the earlier slide to some extent, but it really takes us a little bit farther. So it really is similar to tic-related OCD in phenomenology, more ordering, more arranging, more just right. But the sense is the compulsions are triggered by sensory phenomenon rather than anxiety. The compulsions are less elaborate. So again, they're not so much harm avoidance where you might have more well-developed scenarios of negative situations playing out, but it almost can be just more like a feeling. Something bad, something's not right, a feeling of discomfort. And these Tourettic OCD obsessions or distresses experiences intolerable and unremitting. The compulsions, again, are more designed to address these concerns. And Swedo described a number of associated features with Tourettic OCD. Early sensory hypersensitivity or intolerance. These are the kids that don't like loud noises or bright lights, that can't wear certain articles of clothing, family history of tics, ADHD, LD, impulse control is more common. And these kids have relatively poor response to SSRIs and ERP. So these are the kids that you see, and there are adults like this as well, that it's difficult for them to live in their own skin. And they're tougher to treat. They really are, because these types of symptoms, this type of distress doesn't habituate necessarily as easily as you tend to find with more of the straight anxiety-triggered OCD. So in terms of addressing treatment with these kids, ERP exposure oftentimes needs to be modified to more and longer exposures and more emphasis on distress management tools, as well as the potential use of anti-tic medications. So PANDAS is something that's quite commonly talked about in OCD, especially with children. Pediatric autoimmune neuropsychiatric disorders associated with strep. This has, the criteria are, and this is basically OCD, and it has been expanded to Tourette, to Tics now, even eating disorder and some other issues. Basically, the disorder is triggered by the body's autoimmune response to a strep infection. And the characteristics are of the presence of a strep infection, which then leads to an abrupt, explosive onset of OCD associated with some associated neurologic movements, motor hyperactivity, clumsiness, choreiform movements that really tend to cluster, and the OCD symptoms tend to wax and wane with recurrent strep infection. And a lot of people are coming in for treatment now, triggered by PANDAS. The research, there's some research that supports the validity of this subtype, but there have yet to be definitive studies showing that really how best to assess PANDAS and to really identify it. The important thing here is the fact that treatment of these kids, or these people with PANDAS, oftentimes it's very similar to treating OCD in the absence of PANDAS. So PANDAS has been promoted as a separate disorder in many ways that requires separate treatments, and that's not always the case. In the absence of really definitive research showing that PANDAS is a valid entity and that it's a common entity, a new disorder has been, or a syndrome has been promoted called PANS, or Pediatric Acute-Onset Neuropsychiatric Syndrome. And this, again, would be very similar, abrupt, dramatic onset of OCD symptoms or related severely restricted food intake, along with a variety of additional neuropsychiatric symptoms with similarly severe acute onset, like anxiety, lability or depression, irritability, Tourette's, sensory or motor difficulties. And this is really focusing on this abrupt onset OCD and the assumption then that there's some kind of underlying medical cause for this. But as I alluded to, an abrupt onset OCD, even in the face of strep, doesn't necessarily indicate PANDAS. And one of the reasons for this is that strep is pretty ubiquitous in children. Kids get sick and get sore throats all the time. And having a sore throat or feeling sick can exacerbate OCD symptoms just by the virtue of the likelihood of getting sick. A child with OCD that is going to get sick a couple times a year and may make them worse, doesn't necessarily mean that the PANDAS is the cause of that. It could be a chance association as well. So when we're diagnosing PANDAS, we're looking for a very clear relationship between strep infection and OCD with a significant exacerbation, and we want to demonstrate this over 2 or 3 episodes before we would definitively diagnose PANDAS. When we do suspect PANS or PANDAS, I mean, clearly you want to refer a child for an evaluation, to a physician for evaluation. If a child comes in with a strep or a sore throat or a recent strep, again, we want to refer for them. And then the treatment recommendations are that you would treat the underlying strep or other immunologic problem or other medical condition. You want to treat that the way you would normally treat it. And you also want to treat the OCD still with CBT or medication, because research shows that CBT for OCD works well in kids regardless of their strep etiology. So there are a number of, we also want to be careful not to refer as for first-line treatment really significant disorder, for significant treatments, plasmapheresis, intravenous immunoglobulin. Some community practitioners are referring for these treatments first-line, and they have some pretty significant side effects. So again, my recommendation is that you want to get the strep or infection checked out, but you want to use frontline treatments for CBT, for the OCD as a first line. So let's talk about differential diagnosis. In terms of other anxiety disorders between OCD, we tend to think of symptom content as more realistic. There are no compulsions, social anxiety, even if the child has some unrealistic fears, they're going to be related to social functioning. Separation anxiety is going to be harm to parent. In OCD, we see kids that have worries about bad things happening to their parents, but they're usually in the context of a broader array of OCD symptoms. We also we don't tend to see the same type of compulsions. You may see reassurance seeking, and it may even be somewhat compulsive at times. But in OCD, we're going to be looking for something that's a little more unrealistic, and these compulsions typically are going to be much more excessive or not necessarily related to the fear. For example, needing to count or pray or arrange or something to protect the parents. You see a lot of overlap with pervasive developmental disorders in OCD. If you think about PDD kids or now autism spectrum disorder, kids, you find a lot of perseverative behavior, compulsiveness, and it can be difficult at times to make this distinction. And in fact, OCD and autism spectrum disorders can be jointly diagnosed if you find that both criteria for both disorders are met independently. But ASD symptoms or autism spectrum disorder symptoms that might mimic OCD can be distinguished by the fact that in autism, these symptoms are usually egosyntonic. In other words, the child or the adult derives some satisfaction or solace from these activities, whether it be repeating or organizing or arranging things. And in some ways, that even serves as a method for communication in young children, the way that they might play with something in a repetitive fashion. It's seen as something positive to them. The other criteria would be if you see associated social communication difficulties characteristic of autism, you may be more likely to associate the symptoms with autism rather than OCD. Depressive rumination, in terms of being obsessed or getting thoughts, negative thoughts that may be unwanted. Rumination typically in depression is more mood congruent than OCD. It also may be egosyntonic. In other words, the depressed patient may be more likely to believe or accept these negative thoughts, and you're less likely to see compulsions. Eating disorders, OCD is very commonly comorbid with eating disorders. We see a lot of food-related OCD, very common, but the concern in food-related OCD is typically about getting sick or choking or vomiting as opposed to weight gain or body image. So that's going to be the important distinction, is what exactly is driving this restricted food intake in terms of making that diagnosis. And when we think about other criteria, I already talked about ASD. Paraphilia is gambling. We have a lot of parents coming into us saying, my son has OCD because he's addicted to his video games or obsessed with video games. In terms of sexual paraphilia is gambling, eating. Again, these are egosyntonic, and any anxiety associated with these typically stems from the consequences. Again, OCD, the compulsive behavior is designed to make a bad feeling go away. In paraphilia is gambling, etc. These others, the bad feeling comes because the person has spent too much time in the activity. Hair pulling, excoriation, the symptoms are limited to pulling or picking. These behaviors can be experienced as pleasurable at times. And then OCPD, similar names are really somewhat of a misnomer because OCPD is really a maladaptive pattern of perfectionism and control. The thoughts and behaviors aren't intrusive, nor are they ego-dystonic. This is the way that the individual organizes their life. I'm going to skip this slide because I think we've gone over this enough. But let's talk about tic disorders in the time that we have remaining. DSM-5 tic disorders. So a tic is a sudden, rapid, recurrent, non-rhythmic motor movement or vocalization. And the diagnostic criteria are reasonably straightforward. Tourette's is the presence of both multiple motor and one or more vocal tics present at some time during the illness, although not necessarily concurrent. And persistent chronic motor or vocal tic disorder is single or multiple motor or vocal tics, but not both, have been present during the illness. The symptoms have to have persisted for more than 1 year since first onset. So if you had a couple of tics a year ago and you have a couple of tics today, that would meet criteria for the chronicity. You don't need to have the tics continuously. And in terms of Tourette's, it really is just that you have motor and vocal tics. And a persistent tic disorder would be that you have motor or vocal, but not both. Provisional tic disorder are single or multiple motor and or vocal tics that have been present less than 1 year. And this diagnosis it used to be called transient tic disorder. Tics are very common in young children, 5, 6, 7, 8-year-olds. About 15 to 25% of young children experience tics for a period of days, weeks, or even months. And we don't know whether they're going to develop a chronic tic disorder or not until enough time has passed. So the provisional tic disorder is designed to capture these youth that are experiencing tics, but we don't know whether this is going to be a self-limiting episode or not. And all tic disorders are onset before age 18 to make the diagnosis. A couple of DSM-5 changes. Provisional tic disorder, as I said, it used to be called transient tic disorder in DSM-4, but now it's provisional to reflect the fact that we really are just waiting to see whether this is going to develop into a chronic tic disorder or not. And persistent tic disorder, it used to be called chronic tic disorder in DSM-4, but it was changed to persistent to better match the terminology used with many medical diagnoses. A couple of other changes in DSM-5. The definition of tics is now standardized across disorders. Stereotypic used to be in the criteria to describe tics, and that's been removed because it led to confusion between diagnosing tics and stereotypic movement disorders. And in DSM-4 and earlier criteria sets, there was a criterion that said the absence of a tic-free period lasting 3 months or more. So if you had tics for even 5 years and then you went 3 months without tics, you would lose the diagnosis. And now that's not the case because recognizing the fact that tics wax and wane. And in some individuals, they can disappear for significant periods of time and then come back. There are 2 new diagnoses in DSM-5, other specified tic disorder. And if you give this disorder, you would list the reason that the full criteria were not met. So that might be other specified tic disorder with onset after age 18 years. So the individual didn't have an onset before 18, which is required for one of the formal tic diagnoses. But if the individual did have tics and you wanted to make a diagnosis, you could make it as an other specified tic disorder. An unspecified tic disorder would signifies that there are tics present to some extent, but there's insufficient information to make a definitive diagnosis, perhaps with regard to whether or not there were vocal tics present or whether or not the timing criteria were met, e.g. age of onset, for example. So we know tic disorders are a neurologic disorder. They're not learned, but they're still influenced by their surroundings. And you'll hear more about this in Dr. Wilhelm's talk. Tics are very sensitive to the environment and environmental factors, even though they are neurologic in origin. Tics are more common in males. They're involuntary, but they may be suppressed, and that's another important factor that you'll hear a little bit more about in terms of treatment. And most tics, in most cases, they're preceded by a premonitory urge, which is kind of a sensation or a feeling, an uncomfortable feeling, pressure or otherwise, that may drive the tic. and like a bad feeling. It's almost like scratching an itch would be a kind of an analogy, that you have this feeling or pressure that you need to move, and engaging in the tic relieves that pressure. And tics contribute to social, academic, and occupational problems. Again, they can be significantly impairing disorder. But what you find in some cases is that the comorbid symptoms actually cause more problems than the tics themselves. So you may hear more about premonitory urge in the next talk, so I'm going to skip over this slide. But again, as I said, it's very common, and we see that it precedes tics in many cases. Typically, complex tics are more likely to have a premonitory urge. Simple tics are less likely. The natural course of tic disorders, this is interesting because tics tend to unfold in a very characteristic pattern, and this is really important information in terms of making the diagnosis. And we'll talk about that when we get to differential diagnosis. But the simple motor tics, facial tics, are almost always the initial tics to occur in almost all cases. And we have a median onset of about 5 to 6 years. But again, according to DSM, tics can onset later in childhood and adolescence as well. But it's quite common to see tics initially onset around this time. I mean, we've seen tics in kids as young as 1, and you can have later onset later in elementary age, as I said. But these simple motor tics, so these are eye blinking, is kind of a prototypic initial tic. Eye blinking, eye rolling or darting, facial scrunching, maybe mouth or tongue movements. And these tend to progress from head to toe. So you tend to find these facial tics, and then head tics, head movements, or shoulder or arm or abdominal tics, such as squeezing or pushing out the abdomen, arm and leg tics with hands and feet, and they tend to progress in this fashion. If the individual is going to develop vocal tics, these tend to onset at a bit of a later period, typically between ages 8 and 15, although, again, there's some variation here. But you rarely see a case in which the vocal tics start first. It's almost always these facial tics. The topography can change over time, so the prominent tic for a period of weeks or months or even years may be head shaking, and then it may morph into arm or leg movements. Oftentimes, the new tics are layered on, or they're experienced in addition to the existing tics. However, in some cases, certain existing tics will go away, new tics will emerge, etc. The worst period is typically late childhood or early adolescence, and severity often lessens beginning in mid-adolescence, and up to 50% of cases, in some senses even more, will show full remission by adulthood. So not all kids with tics in childhood are going to have these tics in adulthood. In fact, a number of them do go away. One of the problems is that in spite of a lot of research, we really have very few clues as to which child with tics is going to remit and which child with tics is going to continue with the disorder into adulthood. So the fact that many cases do remit by adulthood is no reason at all to withhold treatment. Prevalence of tics, I alluded earlier to the transient tics, now called provisional tics, can be quite common in young children. But these very high rates of these common facial tics or motor tics in young children tend to be self-limiting, and the vast majority of these transient tics do disappear after a few weeks or a few months. Chronic tic disorders, so the presence of motor tics only or vocal tics only, but not both, a prevalence of anywhere from up to 1 to 2, even to 4% in some studies. Chronic motor tics are quite common. Chronic vocal tics are extremely rare. So it's very rare to see an individual with vocal tics only without any history of motor tics. As I said earlier, the typical onset tics are going to be related to kind of facial motor tics, facial tics typically. So to skip that and have a vocal tic as initial tic is quite rare. Tourette syndrome, again, the presence of both motor and vocal tics was historically thought to be quite rare. Our current best estimate, and this is based on 3 or 4 large studies that came up with just about the same number, is about 6 per thousand, or 0.6% of individuals meeting criteria for Tourette syndrome. And if you look at milder cases, the prevalence may rise up as high as 1%. Comorbidity and impairment. OCD and Tourette's are quite common. Tourette's and ADHD also quite common. So in clinical settings, you tend to find half to even a greater number of kids with Tourette's also have ADHD. It's really mandatory if you're seeing a child for Tourette's to evaluate for ADHD. 50% of kids with Tourette's presenting for clinical treatment have OC symptoms. About a third or more have OCD, actually meet criteria for OCD. Learning problems are also common. Again, these are rates that we see in clinical samples. In the community, these overlaps may be somewhat less pronounced, but again, you are going to see a fair amount of comorbidity in these kids. And we showed, and I alluded to earlier also, is that the number of comorbid conditions you have on top of the Tourette's is going to be associated with greater impairment than TS alone. And in fact, some research suggests that the impairment suffered by children and adults with Tourette's oftentimes is related to the comorbidity more than the specific tics. And within the tics, what we have found is that the best predictor of impairment is not the number of tics, but the complexity of tics. And if you think about this, complex tics, where there may be multiple tics occurring at the same time, can be more disrupting and more noticeable than simpler tics. So stereotypic movement disorders. These are repetitive, seemingly driven and apparently purposeless motor behaviors that interfere with social, academic, and other activities, and they may result in self-injury. So we think about stereotypic, the most common it would be, hand flapping in kids with autism. We see rocking. There may be head banging in some cases. Other kinds of behaviors, compulsive masturbation in young children as well. The typical onset for these behaviors is in the early developmental period, even as young as age 2 or 3. And the way we differentiate these from tics, again, is this younger onset. You tend to see the mean onset age for tics is about 5. For stereotypies is about 2 or 3. Stereotypies are typically not associated with the premonitory urge the way we see in OCD, and they're also less random, and they tend to be bilateral. So tics really are kind of non-rhythmic. They're non-rhythmic. They're random. There may be a head shake, an arm flailing out, a curse, a head to the side. Stereotypic movements are not random. I mean, they really, in some ways, are done in a very stereotypic fashion. Not surprising, given the name, but they're done the same way. It's very kind of a specific structured manner, whether it's rocking or head banging or flapping or whatever that might be. You also tend to see stereotypic movements tend to be bilateral. So again, if it's something that involve both hands, like the hand flapping, you're going to see it evenly distributed. And you tend to see that less likely with tics, again, because they're less rhythmic. And stereotypies are typically experienced as enjoyable. I mean, again, they serve a purpose to the individual. When we think about differential diagnosis with other disorders, you see a lot of kids with ADHD that's going to be comorbid, and people wonder, is the fidgetiness that you see, you're doing an evaluation with a child or an adult in your office with ADHD, and they're tapping their foot, and is that a tic? Or they're looking around a lot, is that a tic? Well, that may be. The fidgetiness tends to be more predictable, and it tends to be longer and done more in an invariant fashion. Again, if that was a tic, it would tend to be less rhythmic and more non-random. We find a proportion of individuals with tic disorders or Tourette's have rage attacks that are associated with the disorder, and these tend to be much more explosive, less controlled. The triggers may be less noticeable than what you might find in a violent outburst with an individual with conduct disorder or aggressive behavior. Profanity, which we find with coprolalia, which really is somewhat rare in terms of Tourette's. Only about 10% of individuals with tics have coprolalia. Again, is typically not volitional. If somebody's cursing on purpose, then that's probably going to be more volitional, and the pattern would be more obvious. Symptoms, chorea is another differential. It's a neurologic disorder. Again, it's a regular and continually flowing movement associated with rheumatic fever. We see in our clinic a number of complex tic-like behaviors where a patient will come in and they may thrash on the bed for 20 or 30 minutes, or all of a sudden fall down, or be sitting on the couch and fall off and start rolling around. And they look like tics, and sometimes they can be somewhat difficult. They can be very, very disturbing to families and to individuals. And there are a couple of ways of trying to determine whether these are tics or not, these complex-like behaviors. The most important way to determine this is, does this behavior occur in the context of a tic disorder? Oftentimes, these very complex and bizarre behaviors come out of the blue. They come when the child is of an older age. In the absence of this characteristic developmental course of these facial tics or simple motor tics at an early age, then followed by the development of more complex tics, it's probably not a tic disorder. Almost all cases have this early development of simple tics, and these complex tic behaviors oftentimes come out of the blue without any history of tics. We would not diagnose that as a tic disorder. Again, tics are relatively brief in duration, and some of these more complex behaviors may go on for minutes or, in some cases, even hours. So that would really not be, we don't see tics lasting that long. And then the other thing we want to look for is secondary gain. So what are the functional analysis? What are the triggers for these complex behaviors? What are the consequences? What is the child gaining or the adult gaining in response to these behaviors? So we really look at these as more learned symptoms or maybe even convergent symptoms in some cases. So finally, how do you differentiate between tics and OCD? This is the big question that everybody asks, given that these disorders are so comorbid. So what we tend to find is complex motor tics or OCD compulsion. And some of the most common types of behaviors that we fall into this category are going to be things like touching, repeatedly touching something, tapping, staring, grabbing, repeating, writing. So there are a number of questions that we ask. What is the purpose of the behavior? Is the behavior designed to make a bad feeling go away, to reduce a fear, or is it in response to a premonitory urge? And again, that's the second question, is another way of phrasing this. Is the behavior preceded by an affective or cognitive trigger, e.g. an obsession, or is it more of a sensory tic phenomenon? Does the patient have other OCD and or tic symptoms? So I have found that patients, even young children, can reliably tell you whether the behavior in question is an OCD or tic, provided that they have other OCD and other tic behaviors. So if we're going to do an assessment with Billy, so Billy, with your tapping that you have to do like 3 times, does that feel more like your other OCD symptoms, like when you need to walk in the straight line, or is that more like a tic when you have to shake your head? And the patients are almost always able to let us know. So if we have a tic-like behavior where the child needs to tap or shout something out in a certain way, and there are no other tics, but the child has an array of OCD symptoms, it's very unlikely that that's going to be the sole tic in this OCD complex. It'd be more likely to be an OCD behavior. Similarly, if a child has tic disorder and no other OCD symptoms, but there is one kind of repeating tic or a writing behavior that looks a little bit OCD-like, in the absence of other OCD symptoms, it's most likely, the conservatively approach would be to consider it as a tic. And again, does the behavior fit in the characteristic developmental course of tic disorders? So did this child with behavior that we think might be tic-like, did this patient start with the child onset of these simple motor tics and progress forward? If not, then it's less likely to be a tic. Now, in terms of treatment, behavioral treatments, and you'll hear more about that in a little bit, it may not matter whether it's a tic or whether it's a compulsion, because the behavioral approaches are pretty similar for both of these. But in terms of medication, it may matter, because for OCD treatment, we tend to use SSRIs, and for tics, we tend to use different classes of medication. So that's the one thing to look at in that sense. So thank you for your time. I think we've gone a couple minutes over, and I just wanted to stop with one of my favorite cartoons, I think, which is apropos for this webinar. So I'll let you guys read that, and I think we have time for questions.
Thank you, Dr. Piacentini. We do indeed. And the first question is the fact that tics can be suppressed makes the description of them as involuntary a problem?
That's a great question. And tics were originally considered to be involuntary. We don't really talk about I think it does make that a problem, but the issue is just because tics may not always be involuntary doesn't mean that they're controllable. So I think it's important to note that if we say that tics are voluntary, then that leads to the next conclusion. Well, if they're voluntary, then they can be controlled, and if they're going to be controlled, then this person should be controlling them and not have tics. And it's not that simple, because tics are extremely difficult to control. They can be in the absence of treatment, they can be suppressed temporarily. In behavior therapy, as you'll learn in the next talk, there are really effective ways of managing tics and learning how to exert better control. But most tics, we think that many tics are involuntary. There are some that are. Not all tics are preceded by a premonitory urge. Eye blinking typically is something that just happens. You may have other simple tics that are very rapid that we would consider involuntary. And even the tics that are more voluntary, the patient still feels compelled in some manner to do them because the premonitory urge can be extremely uncomfortable.
All right. What is the best way to address the delay to diagnosis in OCD?
Webinars like this.
All right, great.
IOCDF, Tourette's Association, other groups. It's just getting the word out. It's educating primary care providers. It's educating the community as clinicians, as researchers, as education. Educators. I think it's incumbent on all of us to really try to educate everybody that we come into contact with about these disorders. A lot of it is stigma and ignorance in the sense of not having this information. So those are the two things that we need to work on.
Great, thank you. And can you address psychostimulants activating tics?
That's a really good question. And there's been a fair amount of research now suggesting that the relationship between, that stimulants can activate tics in some cases. And it used to be that stimulants were never used in children or adults with tics or with a family history of tics. And that was somewhat problematic because in many cases the ADHD was worse than the tics. So stimulant use in individuals with tics now is becoming more common, and it may even be commonplace to some extent. But it does need to be done carefully, and it does need to be done with very careful monitoring. If there is an exacerbation of tics, then when the medication dose is reduced or the medication is stopped, typically the tics will also decrease. But there is some risk there. It really needs to be weighed against the benefits of the treatment against the risks in terms of how interfering is the ADHD. For example, if in a child with ADHD and Tourette's that wants to do behavior therapy, if the ADHD is so bad that there's no way we could do the behavior therapy, then stimulants to help that child focus better, to allow them to do the treatment, might be a reasonable use of that medication.
All right. And what is the comorbidity with a trauma history?
That's a really good question. So we've talked a lot about trauma-triggered OCD, and the fact that in trauma is individuals with trauma. There was a higher rate of I think the original study was a study of individuals with OCD and looking backwards that a number of them had trauma history, suggesting that trauma may trigger OCD. And certainly we see that clinically in some cases. Again, I work primarily with children, and fall is we're really busy in the fall after kids go back to school, and they may have gone from a really nice, understanding teacher to a less nice teacher, going from third grade where school is still pretty fun to fourth grade where it's more work, a death in the family, a move. Situations like this can exacerbate OCD, and it certainly does exacerbate OCD. But in terms of trauma as the primary trigger, the primary cause of OCD, the data isn't so clear on that. There was one very recent study that looked at adverse childhood experiences. There's a scale called the Adverse Child Experiences, looking at things like parental loss, poverty, abusive situations, and a number of other significant child adverse experiences that children may experience. And they showed that these adverse child experiences, or ACEs as they're called, can predict onset of a number of disorders, but there was no relationship between the number of ACEs and the onset of OCD, suggesting that trauma per se may not be a significant etiologic factor for OCD, but in fact it was, but it may predict the presence of comorbid symptoms in OCD, anxiety, depression, other kinds of problems. So trauma should still be assessed in cases that you see, but it may not have a direct relationship to causing OCD. But again, getting back to what I said, I mean, it certainly can exacerbate OCD.
Thank you. And here's the question about Tourettic OCD. Should sensory integration therapy be primary?
That's a good question. There's not a lot of research data. So when we're looking at treatment, when we're trying to put together a treatment plan or talking to parents, we want to start with the treatments that have the most research support for them. So habit reversal training or CBIT for Tourette's, exposure-based CBT for OCD. Sensory integration training has been used for these kids. It has had some good outcomes in some cases. It hasn't worked in other cases. But there's not sufficient research evidence supporting this treatment, at least that I'm aware of, that I would use it as a first-line treatment, perhaps as an adjunct to behavioral treatment, to other kinds of distress tolerance methods. So I think we have really great data on ERP, on CBT, in these cases, and in my mind, that should always be the primary treatment. Now, you may need to adjunct that with family treatments, with mindfulness, with distress tolerance techniques, and sensory integration may be an adjunct in these cases that can be helpful, but not as a primary treatment in my mind.
All right. Thank you, Dr. Piacentini. I think we have time for one more question, and this is it. If a person has a tic that has been going on since before age 18 that he says is involuntary, but he says it also reduces anxiety, is that really a tic, or is this an OCD compulsion, or both?
That's a really good question. And let me just say one thing, that anxiety, non-OCD anxiety, is really common in tics. 30% of kids with tic disorder have non-OCD anxiety, separation, generalized social anxiety, et cetera. And we find that these kids report that stress and anxiety is the number one trigger of their tics. So when they're anxious, they tic more. Now, it depends on what the patient, if the patient is saying, I feel anxious, I tic, it makes my anxiety go away, that, I don't know, that's hard to say. I might think of that maybe more as an OCD symptom, but if he says, I tic, I get really anxious, then I tic, and after I tic, you know, my anxiety subsides in general, that might be something to think about more like a tic. The distinction I'm trying to make is if there's a very direct relationship in the fact of anxiety tic, and by doing the tic, that immediately relieves my anxiety, that doesn't sound like a tic as much as it, in my mind, as opposed to just a general feeling of reduced anxiety after an episode of ticking. And that may be more of a relief. I would really want to find out a little bit better, what is it that he's really feeling? He or she may be feeling a reduction in this premonitory urge, or the distress associated with the premonitory urge, which can be quite uncomfortable. So is it a feeling of relief? Is it an actual reduction of anxiety? What is the specific anxiety? Is the patient worried about social functioning? Are they worried about money? Are they worried about school or relationships? Social anxiety, GAD, or is it just a reduction in distress, in relief, or in an unrecognized premonitory urge?
All right. Thank you, Dr. Piacentini, so much for this valuable presentation. And now we'll take a 15-minute break. I also want to address a question that's come in from our viewers regarding Dr. Piacentini's slides. Yes, they will be available for download along with this presentation and the following one in about 4 business days on the Tourette Association and the International OCD Foundation's website. So, yes, you may download the slides in about 4 days. We'll now be taking a 15-minute break, and for those of you that have to leave us now, I'm going to ask that you fill out this survey. Please just take a couple of minutes and click on this survey link and take the survey. For everyone else who's coming back, for the following presentation of behavioral approaches for treating TS and OCD, take the survey at the end of that presentation. Thanks again, and we'll see you back here soon.